Navicular fracture, two types to consider: the avulsion fracture or the stress fracture. Avulsion fractures typically occur from the ankle sprain mechanism. Navicular stress fracture most commonly occurs in the middle third of the navicular in a relatively vascular region. It's susceptible to delayed union, and it's thought to be due to training error and overuse, most common in sprinting, jumping, and hurdling sports. It's believed to be due to compression from the navicular between the proximal and mid and distal tarsal bones. It's predisposed by reduced ankle dorsiflexion range of motion due to the fact that the midfoot has to compensate and dorsiflex as a result and cause that impingement of the navicular. On exam, tenderness to the proximal dorsal navicular is called the N spot. This should be palpated in the context of clinical suspicion following the classic history of poorly localized midfoot ache radiating along the medial longitudinal arch or dorsal foot that rapidly abates with rest. Investigations considered would be an X-ray to rule out an avulsion fracture or a full fracture, and bone scan, CT, or MRI can help diagnose the stress fracture. Treatment of an avulsion fracture is similar to a severe ankle sprain treatment that we've mentioned earlier. Navicular stress reaction can be treated with weight-bearing rest in an air cast boot, whereas a navicular stress fracture requires strict non-weight-bearing immobilization to start for 6 to 8 weeks. This is 80% successful in terms of return to sport rate, even in long-standing untreated cases. Clinical union is when progression is recommended, such that the cast is removed when the end spot is non-tender. Clinical union is a better judge for progression because CT and MRI serially don't correlate well with union. In delayed union or non-union, surgical internal fixation plus or minus a bone graft could be warranted. Following immobilization, ensure calf strength and mobilization of the stiff ankle, subtalar, and mid-tarsal joints, and correct predisposing factors before resuming full training. It usually takes 6 weeks following definitive treatment to actually get back to return to play. Os naviculare, or an accessory navicular, is a separate ossification center of the navicular. It's joined to the native navicular through synchondrosis, or it's entirely separate. The images on the right show a large cornuate, horn-shaped prominence on the medial navicular, which is how some of these os naviculares present. Of interest, pes planus is no more likely in those with os naviculare than those with a normal navicular. And for those interested in surgical management, only a small slip of tendon inserts in the accessory ossicle. Most are asymptomatic on exam, with just a prominent medial navicular. Those that are symptomatic have tenderness to direct palpation, particularly superior-inferior motion of the navicular, shearing against the accessory navicular. And the tibialis posterior tendon can be painful as a result of passive stretch or active recruitment of that muscle tendon. Investigations such as an X-ray can help define the os navicular. CT and MRI may be necessary for those requiring further intervention. Treatment is typically conservative, involving stretching the footwear to allow for space, minimizing friction from the medial accessory navicular prominence, taping or orthosis to reduce the stretching of the tibialis posterior tendon, manual physiotherapy techniques, and these are typically sufficient, but in those whose pain persists, temporary immobilization in air cast boot with medial wedge, or a special brace that supports the tibialis posterior tendon may enable symptoms to subside sufficiently to enable progression of activity. Failing all these measures, surgical excision of the accessory ossicle is typically successful without rerouting the tendon. In terms of rare, weird, and wonderful causes, pseudoaneurysm after ankle sprain has been described. It's a rare complication of the ankle sprain with only 18 documented cases. All were single case studies in the literature. Diagnosis could be delayed up to 2 months following trauma, but this is the type of case where your clinical index of suspicion has to be up for the persistently swollen ankle following an ankle sprain that's not recovering in the usual time frame. What happens is a pseudoaneurysm forms following localized disruption of the arterial wall, typically of the anterior tibial artery or the perforating fibular artery. So this forms a localized collection within the lumen. This blood collection is progressively surrounded by a fibrous capsule, and it's that makes it distinct from a true aneurysm because of the absence of an arterial wall. Again, on exam, it's the persistently swollen ankle weeks post-injury. More obvious cases would include a pulsatile prominence, bruising, and occasionally ulceration, and rarely but dramatically profuse spontaneous bleeding would be the presentation. Investigations such as Doppler ultrasound, CT, and MRI can help diagnose, but the gold standard is angiography, and there's a couple of images on the right that show this. Again, most commonly it's the anterior tibial artery and perforating fibular artery. Very rarely is it the dorsalis pedis or lateral malleolar artery. Treatment is guided with vascular surgery referral and could involve interventional radiology management or surgical management as described here.